Greetings, and welcome to panel number 2 of our Minority Health Summit here today on blackdoctor.org. If you didn't know, April is Minority Health Month, and we decided to put together a Minority Health Summit to talk about some issues that are disproportionately impacting minorities, particularly Black and Brown people here in this nation. And so we just had a wonderful panel on colorectal cancer. I suggest you go back, but not right now. Go back and watch that panel. It gave some great life-saving information, talked about how you can do a fit kit. I'm not even going to tell you all about it because you need to go watch it. Go watch it. It's life-saving information about colorectal cancer. But this particular panel is one that is particularly near and dear to Black folks because we know about diabetes, AKA the sugar, right? And so when we're talking about diabetes, we just talk about type 1, type 2, controlling your blood sugar. But nobody says the why, right? We know there's some things that can happen, but those are the why. And those things that can happen could have a significant impact on our lives, particularly on the lives of Black and Brown people here in America and around the world, for that matter. So this program is all about the unseen consequences of diabetes. And so we're going to be talking about PAD. We're going to be talking about chronic kidney disease and diabetic retinopathy and all of these words that are alphabet soup, but that you can't really pronounce all the time. But we're going to talk about them today because you need to know that, and that's going to give you the why. So if you're diabetic, if you're pre-diabetic, and we'll talk about what being pre-diabetic is. If you're pre-diabetic, these are some things that you need to be cognizant of so you can try to lower your blood sugar to get back to a normal range, or if you are diabetic, what you need to do to make sure you're taking the right medications and control your blood sugar so you don't hit these other conditions. So I know you didn't sign on to hear me drone on, but let's bring on our first guest. And this is Dr. Valuso Fakariti. He is a wonderful practitioner. I believe, Dr. Fakariti, when you come on, I believe you're a cardiologist by trade. I want to bring you on screen here. I believe you're a cardiologist by trade. And you have chosen, and I've talked to him before, so I'm gonna let the cat out of the bag. He has been here on Black Doctor before. He's wonderful, but you have chosen specifically. I'm gonna let you tell your story as to why you chose to live where you live and your focus of your practice.
Well, thank you for having me. I truly appreciate this opportunity again, brother, to talk to our folks about basically the epidemic before COVID. I mean, I think diabetes is something that has plagued every Black community, not only here in America, but even beyond for decades. And there's a lot of, talk about diabetes. But if you look at our parents my parents both have diabetes, there is a very low awareness and poor understanding of connecting how diabetes can lead to severe consequences, dire consequences, especially in severity of heart attacks, strokes, amputations, dialysis rates, blindness, and also the clinical, economical, and human impact of it. So I decided to move to Mississippi in 2015 because Mississippi has a 40% African-American population. So most of them look like me and you. Mm-hmm. However, it is one of the states out of the 15 states that represent the diabetes belt. Mississippi is the only state out of all those states that every county is represented with diabetes in every county, but it has the lowest number of diabetes specialists. So what does that mean? Every city, town you go to that looks like me and you see high rates of amputations, of heart attacks, of strokes, of dialysis. And our folks just don't know. They don't know how to connect the dots. No one goes out to talk to them about how your sugar can go from, normal level to a pre-diabetic level, as you mentioned, and to a diabetic level, and how that can lead from your blood vessels looking clean like this to looking clogged up like this. And when it's clogged up, you don't have good oxygen flow to your legs. And so it leads to an ulcer that doesn't heal or a wound that doesn't heal. And then you go see a doctor who says, you know what, we just got to chop it off. So that is very prevalent in southern states, particularly in states of color. And so that's why I decided to move down here to try and impact change and affect change.
So you're bringing up a good point. So I'm gonna back up just a little bit and kind of talk about diabetes. You showed two kind of blood vessels, and
Mhm.
how do we get to that with diabetes? Because we just
Mhm.
think about, we've got this elevated blood sugar. So
Mhm.
how does that elevated blood sugar lead to our arteries being clogged?
Sure. There are different factors. We got to understand that it's not just diabetes that sits alone. If you look at all the risk factors for plaque buildup, we call it atherosclerosis, the buildup of plaque and cholesterol. So again, let me show this. This is called atherosclerosis. This happens in all your blood vessels. When it happens in the heart, we call it heart attack. When it happens in the neck, we call it a stroke. When it happens in the legs, we call it peripheral arterial disease, PAD, poor circulation. And when it's not treated on time, it can lead to consequences like a non-healing wound ulcer or amputation. Now, what causes the atherosclerosis are other contributing factors. Sugar accelerates the risk of you building up plaque, but also being obese. There's the correlation between our abnormal body weights and being overweight and obese to diabetes. The fact that our zip codes determines what the prevalence of diabetes with all the sugar we intake, right? All the sweet foods and all the fast food restaurants that are inundated in our communities, specifically and intentionally, historically, by the way.
Right.
And what that leads to is that there's economic inequities, meaning economic inequalities that have existed for decades, and that leads to our folks having poor nutritional access to healthy options. And also when it comes to educating themselves to understand from a health education standpoint or health literacy standpoint, how does sugar and all its content lead to plaque buildup? No one engages them to teach them to understand how to live right, how to eat right, how to diet, how to exercise. So all those things and the lack thereof, plus the fact that we have patients who have other risk factors that contribute to diabetes, high blood pressure, high
Mm.
cholesterol. They work in concert, and when they work in concert, it increases your chances of an amputation by 28-fold, 28 times as a diabetic. And if you're Black,
Right.
independent of your socioeconomic status, independent of your wealth, independent of your educational status, being Black increases your chances of undergoing an amputation 3 times higher compared to your white counterparts. So there is systemic discrimination and racism in healthcare, and we'll talk about all that today.
Yeah. That blows my mind, right? Because we always knew in this country, I mean, we know that race plays a factor, but we know, hey, money, you can always socioeconomic status kind of evens it out. But you're saying, hey, it doesn't even matter if you even control for all that. We're still 3 times higher to have an unnecessary amputation. Um, what do you mean? And that's an interesting phrasing. What do you
Yes.
mean by unnecessary amputation?
Well, unknown to many folks, especially those with diabetes, is that 90% of every person who's undergone a major amputation, meaning anyone who's had any limb taken off from above the ankle or below the knee or below or above the knee, 90% of all those amputations are preventable.
Mm,
90%. So this has become a racial justice issue. Why is it preventable? Because if you can slow down the progression of your diabetes, and you start treating people with effective medicines, and you're giving them healthy options to diet, and you're educating them about lifestyle changes they need to take. Plus, if they have the narrowing of the plaque buildup, and this is going to be my best friend today, this model.
right.
If you're clogged up in your kitchen sink, right? Who do you call? You call a plumber to come and unclog it, right? So that it
Mhm.
could look something like this, right? That's what we do in our
Right.
houses, right? It can happen too in your body, and you call an interventionalist or someone who can work with wires, balloons, and stents to go unclog your arteries. And 90% of the time, the procedure is called an angiogram. 90% of the time, that decreases your odds of undergoing an amputation. So you have 90% chance of walking away with your limbs on intact. But guess what? That is not offered to 90% of the patients who live in majority Black communities, number
Mhm.
one. Number two, an amputation first strategy is what's offered to a lot of folks who have that condition. Number three, and this is the saddest one. If you're diabetic and you undergo an amputation, 80% of them will die within 5 years. So it's not only the fact that we're not treating them upstream, like screening for it and treating it with medicines, but when it comes to procedures, they're not undergoing the procedures they should go that are limb saving. And when they do undergo the amputations, which is very catastrophic, not
Right.
only is it deadly, but it's costly. An amputation, the lifetime cost to a family is about $500 to $800,000. And this predominantly occurs in communities of color in the South. Now, what is the median income of all the states in the South? 45 to 40, 39 to 45,000.
Right.
They cannot afford it. So it is a clinical, economical, and human impact. And that's why I keep on talking about this. It has to stop.
The first question that comes to my head is why? I started thinking about the day-to-day impact of what it would be like to lose a limb, right?
Mm.
To lose a leg from below the knee, to lose an arm, whatever, and what kind of life adjustments you have to make for that alone. And then you're saying is more costly, and the survival rate is 5 years or less.
Yes.
Why then are there more amputations being done? Why is that the first choice instead of what you do, which is calling the plumber and cleaning some of that stuff out?
Because folks don't know what they don't know, right? So our folks don't know what they don't know. And if talk about generational mistrust, everyone talks about Tuskegee, but let's talk about families who've witnessed their uncles, aunts, brothers, and sisters undergo an amputation. They went to the hospital just for treatment of a non-healing wound and ulcer. And they went to a hospital, and some surgeon or some doctor says, you know what, we're just going to treat this with antibiotics, and we're going to treat it for a month. And they don't give them the appropriate workup where they need to see a vascular specialist like myself, who can decrease the odds of you losing that limb by 90%, or a quality wound care specialist who can heal that wound, right? So they don't give them those tools in the toolbox that they need to have a fighter's chance to live their best life, as we say, right? So we want equity. So that is not offered, number one. And number two, what's not done upstream is that we have a sick care system, meaning that we do not institute preventative measures in our healthcare system to prevent people from going into hospitals. We focus more on hospital care. We need to start focusing on preventative care. So what do folks need to know upstream so that they can not have the progression of plaque to a point where we're here fighting not only for the heart attack, the stroke, but the amputations? The cost to the healthcare system, that's a $327 billion a year cost. What can we do with $327 billion? I don't need to tell you, but you and I know that is a deficit. And guess who pays for it? This is the best part. If you pay taxes, 80% of that bill, of that $327 billion, is paid from tax dollars, because that is hospitalizations, that is skilled nursing facility costs, that is hospice, that is nursing homes. You talk about everything in your Medicare Type A, Part A. That is what that deficit is. It's called the Hospital's Insurance Trust Fund. $327 billion. So the consequences of an amputation or diabetes is not just your legs. It's also your heart, it's stroke. They're all related. So we need to start doing better at meeting our patients and educating them upstream, empowering them, right? Teaching them, giving them the tools, just like we're doing today.
Yeah.
Tell them about how to not have that prediabetes become a diabetes, or if you have diabetes and you have symptoms. And here's the problem with the symptoms of peripheral arterial disease. They're slow and progressive. So some people have this numbness, tingling, burning called neuropathy.
Okay.
And neuropathy signs actually can increases your odds of an amputation by 1 to 3-fold. Neuropathy. Okay. Not only that, retinopathy, your eyes, or your kidneys. We have a kidney specialist. We call that nephropathy, when you got some protein leaks in your kidneys. So all these things can actually lead to early warning signals. It's not just your common, I have pain and cramping in my foot, because not everyone presents that way. Some people are just, my legs give out. My one foot is cooler than the other. My toenails look funny. They look yellow.
Right.
So the fact that we need to start encouraging our patients to look out for those warning signs, have someone take off your socks at every visit when you see a primary care doctor or vascular specialist. Let them check your pulses in your feet. Go see a foot doctor, podiatrist once a year. Go see an eye doctor once a year. Make sure, treat yourself like a very expensive car. right? Like that Bugatti. Don't be a regular. No offense. Don't treat yourself. Make sure that they do everything because you're paying for it. That's your insurance. That's what you pay for.
Right.
So and it's sad because your insurance status actually is one of the what I call the amputation lotteries of America. It's not just your race or living in the South, but also if you're uninsured or underinsured, you're more likely to undergo an amputation because you're not given all those resources from a prevention standpoint
Right.
as someone who has a better insurance plan.
Okay, so a couple of things came to mind as you. Thank you for laying that out. So one, it sounds like sick care is big business,
Mm-hmm.
right? And so there's a lot of money that's being made by just keeping people, doing interventive care versus preventative care. The second thing is, if I am let's say I'm a diabetic and I'm just going to see my primary care physician to get my medication. He checks my blood sugar, he or she, I don't want to make that gender specific, checks my blood sugar, and I leave, everything, I just go get my new prescription. But there's something wrong, right? I'm starting, doc, I'm having some numbness and some tingling. How do I get from that with my primary care physician to see you to where we can clean that out versus to go see the person that's going to do the amputation?
Man, brother, it's like you read the textbook. Here's the problem. There's a lack of awareness of peripheral arterial disease, which is that condition you just eloquently described in simple lay terms. The prevalence of peripheral arterial disease affects 20 million people in America, but only about 12 to 18% of Americans actually know. And the lowest awareness rates of peripheral arterial disease and their symptoms are in the Black community. One. But also, I'm not done. Medical schools are not doing a good job teaching primary care providers. So a lot of providers actually do a poor job of diagnosing and treating peripheral arterial disease because some of what I call the preventative task force, the U.S. Preventive Service Task Force, which is a body that lays out the guidelines for who do we screen for PAD. It's kind of like, we just had a colorectal cancer event. Who do we screen for cancer? Why do we screen for cancer? Because it's slow, it's deadly, it's progressive. Some symptoms are very silent, and it's costly. Well, what does that sound like? Sounds like peripheral arterial disease. Well, the reason, and it's 5 times more costly and deadly than your simple skin, breast, and colon cancers, by the way, peripheral arterial disease. Okay. It is more deadly. But there's a lack of awareness. So what people need to do is that, one, they got to know their risk factors. If you're over the age of 50, or you've had a family history of anyone who's lost a limb, or if you've had a heart event or a stroke, or if you've had high blood pressure, high cholesterol, or you use nicotine products, you smoke, you dip, you chew, because some of our folks don't smoke, right? They dip and they chew. Right. If you do any of those things and you go see a doctor, tell them that you want to check your circulation in your legs and your feet, and tell them that you want your socks off. They should check your pulses. And there's a non-invasive test called a vascular test called an ankle brachial index that will test to see if you have any signs of poor circulation. If it's abnormal, they refer you to a specialist. And if your primary care doctor does not do that for you, guess what you do? You take your Southern hospitality with you, and you go seek a second opinion.
Okay. And I think that's the most important things that people know. They need to know what questions to ask, what tests to ask for, to push their primary care physician from, you need to go cut it off, to, hey, let's do some regular checking of these areas, especially if you show some signs. Even, I think, sounds like you're saying even before there's some signs. Just
absolutely, because just like cancer, right? We don't want to start catching it when there's signs. That's bad.
Yeah.
If you have the risk factor, period, you want to be screened. And so the guidelines have to also adopt this, because we are losing limbs in the Black community at a rate in which we're not only absenteeism or talk about loss of productivity, but the cost to our societies. We cannot afford that. We're now seeing peripheral arterial disease show up in the Black communities 10 years earlier because diabetes is showing up earlier. Black and brown kids aged 10 to 19 have the highest prevalence of diabetes compared to all their other racial counterparts. Wow. We're now seeing that the death rate from diabetes went up by 15% last year. Right? You know what I'm saying? So we can't afford this. This is the epidemic of proportions that is predominantly because due to the fact that we have not addressed the social determinants of health in our communities, which is basically all the medical factors, the economic inequities, education inequities, physical neighborhood, what redlining did to our neighborhoods, where even my folks cannot even go exercise. There's no sidewalks for them to exercise. Right. And so part of the treatment of PAD is to tell folks to go exercise. Well, I'm going to exercise.
Right.
So when the guidelines are written, it makes you wonder who are writing these guidelines. Another food for thought, because now you understand that they need to understand all the inequities that have historically and intentionally been designed and have led to systemic inequities in care and in treatment and outcomes.
I could talk to you all day, Dr. Fakariti, but we've got some other guests we got to get to. So I want you to stick around.
I'm gonna shut up.
I want you to stick around though, because I definitely want to get to ask some questions later at the end of the program. So we're going to bring you back at the end and so if you have some questions, if you're just joining us, we're talking about the unseen consequences of diabetes. We had our first guest, which is Dr. Fakariti, who is a PAD specialist. I can't say it, but just basically he's a plumber for your veins, and he will
arteries.
For your arteries, and he will help save a limb. That's the bottom line, versus getting unnecessary amputations. And he talked about the rates in terms of unnecessary amputations, particularly in Black communities. And so he has dedicated his career. He is in the heart belt of the South there in Mississippi doing that great work. So we're going to bring in our next guest here. And our next guest is Dr. Lenoir Coleman. And she is not a stranger to blackdoctor.org. She's a pharmacist, and she is particularly interested in, she is the CEO and founder of Healing Our Village, and she is particularly focused on diabetes. And so welcome to the program, Dr. Coleman. It's great to see you again.
Hi, how are you? We actually had blue skies, and now it's getting cloudy here in Atlanta. But letting me come on board here. We're out right now at an apartment building in Morrow doing a health fair, which is what Healing Our Village is really focused on. And, Dr. Fakariti said something so important is we have all of these issues. We're dying from things that are treatable and preventable, but yet we do nothing to try to get to do better. I haven't figured that out. I just don't understand it. We've been there since 11. We've screened one person.
Oh wow.
One person.
So let's get to the numbers, because I know you're great with the numbers. How many people are diabetic in the United States?
Oh boy, so about 36 million are right now that we know of, right, have diabetes, because there's about 7.3 or so million that don't even know they have it. Okay. Especially African Americans, especially African American men are not going to the doctor, so they can't get diagnosed if you don't go to the doctor, right? And we know the majority of that 36 million people have type 2 diabetes, all right? Very few, only about 5% or so of those have type 1 diabetes. What I'm most worried about right now is prediabetes. Okay. And there's about 88 million and counting people with prediabetes. And the reason I'm worried about that is during that time when your blood sugar is 101 milligrams per deciliter, so normal is 60 to 100. Once you hit 101 to 125 milligrams per deciliter, so if your doctor does a blood test and does your blood sugar, or if you have a blood glucose meter and you test your blood sugar in the morning and that number is 101 to 125, you have prediabetes. And the reason I'm worried about that is because, today we're talking about eye disease. Mm-hmm. Well, these high sugars affect the eyes. They affect the nerves. They affect the blood vessels in the kidneys more than anything else. And so that's why it's important. We got to get your blood sugars down to below 100 is where we'd like you to be. Right there at about 90 would be perfect, right?
Right. So, all right. So 88 million prediabetes, 36 or so million people that we know are diabetic, but another 7 to 8 million people that don't know that they're diabetic, but are walking around diabetic. Oh, okay. So how do we lower our blood sugar naturally? What are some things that people can do if we're in that pre-diabetic range, that 101 to 125 you talked about? What do we do to lower that range?
Okay, so I are part of the 88 million because diabetes runs in my family. So this is very, very common in families, African American families. What I'm doing, I can just tell you what I'm doing. So what I'm doing is trying to decrease the amount of carbohydrate. So starches, sugars, concentrated sugars, so juices that have sugar. So the first thing I did was stop drinking my calories. So all of the drinks that I drink are sugar-free. Gotcha. There is no sugar in what I drink. That's very important. So everything I drink, I look at the label, and I can see if there's sugar in it, and I count how many calories is in it, and it shouldn't have more than 5 calories. So that's the first thing. Number 2, what I'm doing is watching my portions. So I tend to overeat. I have a struggle with my weight my whole life. I go up and down and up and down. I probably lost about 20,000 pounds, like 75 pounds. So I keep losing and gaining and losing and gaining and losing and gaining. Okay, so this is hard for me. So I can relate to my patients because they're struggling. So what I try to do is not eat so much. I stop eating after I'm about 80% full. All right, so that's the first thing. So that's the second thing. The third thing that I'm trying to do is eat less meat. Now, I'm a meat lover. I love a ribeye steak. I can eat ribeye every day, okay? But I'm forcing myself to eat chicken and forcing myself to eat more fish. I don't like fish. There's a lot of African Americans that love fish, Yeah. So that's wonderful. If you're a fish lover, try to eat fish all the time, right? Now, not shellfish. Yeah. Because shellfish increases your cholesterol, and most people that have diabetes also have high cholesterol, most of them. So, but you can eat all of the fish that swim. Any fish that's in the ocean swimming, that's the one you want to eat, right? If they're just hanging out like a salmon from a salmon farm, and that salmon ain't trying to get back to mate, right? We need wild salmon. You're going to eat salmon, right? Because that means they're working. Everybody's got to work. Your food needs to work. It's important. It's really important. Your food has to work for you. That's the other thing. So I'm trying to eat more vegetables. So there's some vegetables like I really like. Like I love spinach. Okay. I can eat it raw. I can just throw it in the underneath the broiler for just a minute or so and throw a little cheese on there. I mean, I can eat spinach every meal. Okay. Right. And I'm trying to eat more soups, especially in the evening hours. I'm trying to have more soups and salads in the evenings and heavier meals around lunchtime. So these are just simple, tiny things that you can do, all of which helps to just decrease your blood sugar so you're not having these big spikes in your blood sugar. You don't want the spikes because the spikes is what causes the eye damage and the heart damage and the kidney damage and the nerve damage. Okay. So we got to keep our blood sugars as even as possible. That's very important.
All right. So a couple of things as we're wrapping up, because I want to share a special tool that you have created so people can help with their diabetes. So one thing I want to share is like when you were talking about when Dr. Coleman was talking about lowering your portion size. The portion size is about the size of the palm of your hand, right? So I know we go to these restaurants and we get those big things and we're excited because we go to a restaurant. Oh, we get this big mountain of food on our plate, and we learn from back in the day. If you had a mama like mine to say you got to clean your plate, and you do that, and you stuff it, and you're. This is the portion, right? Your plate, so we're trying to eat a more plant-based diet. Your plate should be 50% fruits and vegetables, 50% fruits and vegetables, 50% fruits and vegetables, 10 to 25% of meat, a little lean meat, fish, lean chicken, and the other you can have some fiber, some kind of more complex carbs like brown rice, black rice, your quinoa, none of that white rice. Those, if you're trying to put together a plate, those are the things. Legumes. Thank you. Those are some wonderful things that you can do. The second thing is you developed something a wonderful tool to help people with diabetes. Tell us about that tool.
All right, so I have developed an app. Everybody's on their phones like 24/7. So I developed a mobile app called Step Up 90. And what this app is going to do is, for those of you who are in that pre-diabetes range, and for those of you who are overweight, your BMI is 30 or greater. And if you don't know what your body mass index is, BMI, just go right now. You can go to Google after the show, put in BMI calculator, put in your height and your weight, and it will tell you what your BMI number is. And it needs to be less than 30. If it's greater than 30, then my app is something you need, because it will help you lose that 5 to 10% of your body weight over a year period of time. And so this app has recipes, and it has classes that you can watch on your phone, on Zoom, and it has line dancing you can watch on your phone. And we're going to be doing cooking demonstrations, and I'm doing some Zumba. So I'm doing all these really cool things. And once a week, you'll be able to meet with my coaches, and we take you through a year-long curriculum to help you learn to eat healthy and to decrease your blood sugar. Step Up 90.
Yeah, so we got a short video here of the kind of video demonstration of the app. So let's play it right now.
Hello, I'm Dr. Lenoir Coleman, president and founder of Healing Our Village. Did you know 88 million people in the United States have prediabetes, and that number keeps growing? Did you know that more than 2 in 3 adults in the United States are either overweight or obese? Healing Our Village is excited to introduce Step Up 90, weight loss and diabetes prevention program, all in one. Finally, there is a guided mobile app that will help you lose 5 to 7% of your body weight and help you get your 150 minutes of exercise in every week. All of this is available on your cell phone, notepad, or computer. To install Step Up 90, all you have to do is go to www.stepup90 from your phone or computer and hit the install button. Once the icon is added to your home screen, you can create a unique login and password, or use your Facebook or Google login credentials. Do you have prediabetes? Does diabetes run in your family? Well, once you log in to Step Up 90, you can take the diabetes risk test. If you score more than 5, you may be at risk of developing type 2 diabetes. Step Up 90 features the CDC-approved Prevent T2 program, along with their food log, fitness log, and action plan. All materials can be printed or downloaded for easy use. Our monthly calendar provides our virtual class schedule with a reminder 30 minutes before the class to help you remember. Are you looking for easy to understand lifestyle videos, healthy recipes, exercise classes, nutritional support groups, or a cooking demonstration? All of this is available with our premium package. The most unique feature of Step Up 90 is your ability to chat with your lifestyle coach, a clinical pharmacist, or a registered dietitian. These experts will have weekly office hours. They are there to help you achieve your lifestyle goals and manage your medications. Sign up today for Step Up 90. We have our basic package starting at $5.99, featuring our weekly Zoom classes, and our premium package at $19.99. Step Up 90, it is time for you to step up.
Wow, that sounds like a wonderful tool to use, and we're gonna ask you some more about that. But we got to get to our next guest, so just stick around for us, because there's some questions that are coming in from the comments that we're gonna make sure that we get asked of you. So hang around for me just a little bit, Dr. Coleman. But thank you so much. That's a wonderful app.
Thank you so much.
All right, moving right along. Next up, we have Dr. Ashtay Collins. Welcome, Dr. Collins. Dr. Collins is a nephrologist. Always have to say that, nephrologist. And so help people understand what a nephrologist does.
That's the most important question here. Many times, when someone says, "Oh, I'm an ophthalmologist or cardiologist," people know exactly what that is. A nephrologist is a specialist of the kidney. So I deal specifically in kidney disease and hypertension. If you're on dialysis, I'm your guy. If you are at risk of needing dialysis and you don't want to go on dialysis, I'm especially your guy.
Okay, so kidney specialist, what role does diabetes play in having somebody develop kidney disease?
Right. So, chronic kidney disease in the United States, it affects more than 1 in 7 adults. So about 37 million people. And unfortunately, about half of them have diabetes. And to this day, diabetes is the #1 risk factor for the development of chronic kidney disease. So we really worry about it in any person with pre-diabetes or diabetes. And all of those people, in my view, and in all of our society guidelines view, should be getting screened for chronic kidney disease.
So we're talking about chronic kidney disease. I understand there's some stages that happen, and what is the interplay like? So we're saying, so diabetes is a risk factor.
Yeah.
How does that increase our risk? I'm trying to draw that correlation from uncontrolled or poorly controlled diabetes to chronic kidney disease.
Great question. So when the blood sugar remains elevated, it drives a process of inflammation in the body, and especially in the kidney, because the kidney's job, when you think about it microscopically, there are about 1 million tiny filters in each kidney. And their job is to get rid of whatever the body doesn't need anymore. So most people associate the kidneys as the organs that get rid of waste and toxins. But when the blood sugar stays high, there are these very tiny blood vessels inside of the kidneys, and the high blood sugars cause a direct attack on those filters. So it causes a thickening of those filters. So over time, you have a decrease in the amount of waste and toxins that the kidneys can filter out. It's kind of tricky with kidney disease. In the initial years of it, the kidney function actually increases a little bit, maybe 5, 10, 15% over a person's kind of native kidney function. But over time, we'll see 2 things. Number 1, a decline in the amount of waste and toxins that are getting removed. And number 2, we'll start to see protein start to spill from the kidneys. I like to think of it as the kidneys being the filter. Think of the air filter in your house, right? In your air conditioning unit. Right? It has all these fibers in it, and it's supposed to block the lint and the dust and let the clean air pass through. Well, the kidneys are trying to do the opposite. They're trying to let the bad stuff pass through into the urine and keep the good stuff behind. So under normal circumstances, the protein that's in your body, and especially in your bloodstream, it should stay in your body, in your bloodstream. So when there's enough damage that's done to those microscopic filters, we start to see that protein leak through the filter and show up into the urine. So that's part of how we define diabetic kidney disease, as that drop in kidney function and the appearance of protein spillage into the urine.
No, that was a wonderful example, because I didn't know, right? I knew that there was a correlation, but just not understanding how that process worked. You did a great job of explaining that to us, and so thank you so much for that. So there's a question from the audience that says, if you already have protein in your urine, can it be reversed?
Well, to some degree, it can be. Sorry, I had to change my microphone. Is my sound still okay?
Yeah, you're still
okay. Great. All right. So there can be a reduction to some degree, and part of that is related to blood pressure control. So getting to brass tacks, when someone already has protein spillage into their urine, and in the presence of diabetes, and people look at me and they say, "Doc, what should I do about it?" I come up with this top 10 list of things, but really at the top of the list is blood pressure control, blood sugar control, and restricting the amount of protein that you're actually bringing into your body. Not because the protein that comes in immediately leaks out from the kidneys, but high protein diets. And most people on a Western diet are probably bringing in more protein than they should be. You talked earlier about portion size, right? That the amount of that you're eating should be about the size of your hand. People with diabetic kidney disease should only be eating about 0.8 grams of protein per kilogram of body weight. So you find out how much you weigh in pounds, divide that by 2.2 to get to kilograms, multiply that by 0.8, and that should tell you about how much protein you should be bringing in per day. What I worry about is when people eat the same amount of protein year after year after year, that actually drives up inflammation, and that can actually increase the amount of protein that spills from the kidneys into the urine. And what that actually does inside of the kidneys, it's okay for the protein to pass through the blood vessel, but once it passes through the microscopic filter, it actually drives a scarring process inside of the kidneys. And while you can reverse the protein spillage to some degree once it's early, I haven't figured out a way to turn scar tissue back into normal, healthy tissue. Right. Whoever figures out how to do that, they're going to win the Nobel Prize. They're probably going to become very wealthy, but we're simply not there yet. And that's the trickiest thing with chronic kidney disease related to diabetes. I kind of think of it like, think of the gas tank in your car, right? Your car pretty much drives the same, whether it's at a full tank of gas, a half tank of gas, maybe even a quarter tank of gas. Your mileage might suffer a little bit, but you don't feel like your car is sputtering just because you're at a quarter tank of gas. That's what happens with chronic kidney disease. You can lose kidney function and not have any symptoms until it's at the very end. And once you're at the very end, once that gas tank is running on E and the car is actually sputtering, there's so much scarring in the kidney that there isn't anything that we can do to turn it around. So I want to highlight the importance of everyone who's listening and everyone who's in the families of the people who are listening to go get checked out, get screened. I can't begin to tell you how many 50-something and 60-something-year-old people that I meet who hadn't been to the doctor in 10, 15, 20 years because they felt fine and they were only driven to see any doctor because of symptoms. This is a silent killer of too many Americans, because by the time you start to see consequences of chronic kidney disease, there simply isn't anything that I can do to fix it. So we got to catch it early so that we can slow down the progression and keep people's kidneys healthy.
Okay, so what are those screenings that we should be getting done?
So the first part of it is simply getting your standard blood work done. When you see primary care and they send you for what we call routine blood work, one of the tests that's on there is going to be either a basic or a comprehensive metabolic panel. And what it does, it checks all of the electrolytes in your bloodstream, it checks the acid level, and it also checks a test called the creatinine. And that is a protein that actually comes out of your muscles. It's a waste product. It's not toxic to you, but by the time the muscles release it, your body simply doesn't need it anymore. So in a healthy kidney, it should be constantly getting rid of creatinine. So when we check the blood test for creatinine, it should be a low number. For most people in your audience, it should be a number right around 1, maybe even a little bit less than 1. Okay. Once we start seeing the creatinine rise above what I would expect for your gender, with the expectation that a man would typically have a little bit more muscle for a given body weight than a woman. So there's different ranges of what we call normal for creatinine for men and women. Once the creatinine rises above that range, then I worry that the kidneys are not doing a good job of getting rid of that creatinine. And that's one of the signs that we can tell that someone has diabetic kidney disease or just chronic kidney disease in general. Number 2, we actually do a urinalysis and a urine protein measurement. We might not be doing that for every single person that walks in through the door, but if you certainly have an elevated creatinine or a history of diabetes, measuring a urinalysis and measuring the urine protein is going to be a very important screening tool to figure out if you actually have chronic kidney disease related to diabetes.
Well, those are 2 good things to know. So creatinine, get that test, know what it is. It should be 1 or less than 1, just less than 1.
Yep.
There's a gender component. So ladies, understand your doctor. And number 2 is that protein. Right? And so I've been hearing this funny thing, and I'm going to say it, and it's always funny to hear about it. Foamy urine.
Yes. I'm so glad you brought that up. People will talk about having frothy urine. The way I usually describe it as if you can imagine a glass of beer being drawn from a tap at a bar, and the foam that you would see on the top of that beer, that kind of foam that stays in the toilet even after you're done. I'm not just talking about the bubbles that would normally form just as a result of urinating naturally. That is a sign of a very large amount of protein being spilled. I want to catch people with diabetic kidney disease before they ever get to that point. Because by the time you can see the protein, the amount of protein is at such a high level that I think that there's a lot of scarring that has already happened, and our options become more limited with what we can do to slow down the progression.
Okay, so I would ask more, and I want to talk about dialysis and all that other stuff, but we're going to get to our last guest, and then we're going to bring everybody back, and we'll wrap up this conversation. So our next, but thank you, Doctor. Boy, that was good stuff. That was good stuff. Hey, scarring happens. Okay, all right, we're learning today. This is all related to diabetes. Diabetes is all connected. So we talked about amputations. We've talked about kidney disease. We got an app now. So we're going to get to our last guest here. Is Miss Nicole Jefferson. And Miss Jefferson is, and I'm gonna let you tell, she's gonna tell her story with her bout with chronic kidney disease. And these are some of the, and I don't know if your chronic kidney disease was a result of diabetes?
No, actually, we aren't sure. We believe it may have been high blood pressure. However, through my journey, I did develop diabetes after transplant.
Okay, so kind of talk about your journey and how was that process for you with chronic kidney disease, because you went all the way through a transplant.
Yes, I've actually been through 2 transplants.
Oh wow!
And the reason that I wanted to make sure that everyone understands in the audience is diabetes is the number 1 cause of kidney failure. High blood pressure is number 2. Again, we aren't aware of what happened with me, because as the other doctors stated, a lot of times things aren't checked. I was literally at the doctor's office a week before I went into the hospital, and they found out I was in kidney failure and had to start dialysis immediately. So while you're being checked, you have to make sure that they are checking for the correct things, making sure they're checking your high blood pressure. Something as simple as that. They kept saying, we can't seem to get your blood pressure number. It's probably something wrong with the machine. Well, there was nothing wrong with the machine. It was just simply that my blood pressure was too high, and they didn't raise it enough because they thought surely a 31-year-old person doesn't have high blood pressure, not taking into consideration everything that surrounded that. I was a Black woman raising a young child, living in Texas, being in a high demanding, being in technology. They didn't take into consideration all those other things that could have possibly led to high blood pressure for them to check. However, as I stated, I started dialysis immediately. And, through there, I had, of course, challenges. And, one of the things that I've noticed now, hindsight, is that I wasn't aware of a lot of things because they just simply didn't tell me. And I believe that to be because I was a person of color. So living in Dallas, living in Texas, there are a lot of people on dialysis, a lot of people who need kidneys. So it took a while for me to receive a transplant. The first one, it took approximately 5 years. So 5 years of me on dialysis, 5 years of my body continuing to go down by even being on dialysis. So I did receive my first transplant in 2008. And, most people think, and I thought that meant I was cured. I didn't realize that it was just another treatment. So a transplant is no different than dialysis or any other treatment. It just simply means I don't have to do dialysis. The dialysis that I chose was actually an overnight process at home because I didn't want to go to a clinic. So that just means I don't have to connect to myself every single night. So, one of the things that I want to stress also is making sure that if you feel something is wrong with your body, scream it out and make sure that it's known to your doctors that there's something going on. Sometimes numbers don't tell the truth, and I go based in, for me in particular, everything may look okay, but it never is. So as I said, I was transplanted in 2008. around 2016, I just had this weird feeling that the kidney was failing. So I met the nephrologist. I'm, speaking with my by that time I was living in Des Moines, Iowa. So I kept telling my nephrologist something is wrong. And he said, no, there's nothing wrong. Your creatinine, as Dr. Collins spoke about, your creatinine is staying at about a 2.6, and it looks like that's where your baseline. We know it's declining, but we don't think it's that far gone. And I kept asking, can you please do a biopsy? I really need a biopsy. And a lot of times doctors don't really want to do that. And so he, refused for about 6 months until I finally told him, well, I'll go to Texas. I know a doctor who will do a biopsy for me because there's more to this than what these numbers are saying. So finally, when I said that, he said, fine, I'll do the biopsy. And he did the biopsy and he called me and he said, you do know your body, don't you? I said, I sure do. He said, yeah, well, this kidney is 90% scarred. You need another one. So if I had just been looking at those numbers, because of the biopsy, I was able to be listed for transplant again. If we had just been looking at numbers, my numbers didn't go to transplant numbers for a few years after that. Luckily, I had already been listed in other locations, so I was able to receive a transplant before dialysis the second time. Okay. But, the thing that I want to stress is, with this is making sure that you are going with your gut and making sure that they are doing the testing that you need. And if they don't want to do it, tell them you'll go to someone else who will and find someone else who will. After my first transplant, I developed diabetes because of the high amount of steroids and medication I was on. I was able to finally get off of medication, but with my second transplant, I received a second transplant. By this time, I was back living in Texas from Iowa. However, I knew that Iowa had a very high turnover rate, and they do transplants pretty fast. So I decided to go get listed in Iowa. And so luckily, I was able to be transplanted fairly quickly, within about 5 months of me being listed, just because of the way that they tend to do transplants. They take a little bit more risk than other people will. And I was fine with that because I didn't want to go on dialysis. But right now I'm back with diabetes with this second kidney, and I'm fighting this. One of the things that's hurtful to me is that I do have to manage and make sure that my diabetes is in check, so it won't cause harm to this new kidney. I don't want to harm it with diabetes, of course. So I make sure that I make sure that I have the correct monitoring system for my glucose. I had one monitoring system. However, I didn't feel it was accurate. And so I actually went to my doctor and said, I don't feel this information is accurate because it's not based on how I feel. Another thing is making sure you understand how you feel and how you're supposed to feel with this when you have diabetes. So I was able to ask for a different type of monitoring, and that particular monitoring is giving me accurate numbers, and I'm able to treat myself based on that. Another thing, I have just had my significant other change doctors. Like you said, a lot of Black men don't like going to the doctor, and the doctor came back and advised him that he has, that his AC1 was extremely high, was at about, 6, showing diabetes. And of course, you know how Black men don't like doctors. So he, of course, was upset, blamed the doctor, and said he was going back to his doctor. Right. And I explained to him, I said, I explained to him the A1C looks at 6 months, a 6-month period. And you've been to your doctor 3 times in that 6-month period, and he's never checked your A1C. That's problematic. If you're going to these doctors, you have to make sure that they are checking these particular numbers. A1C is a quick, easy test, and it can tell you how your numbers, your sugar numbers look, glucose numbers look within a 6-month period. And that's what we need to know. And that's what I want, underserved populations and people who look like me who just aren't aware because the information is not getting to us, things that we have to check for. So making sure that they are able to get the high blood pressure, to check your blood pressure, making sure they are able to, check your A1C and get that information. So you can avoid situations like this, having to be transplanted, having to go on dialysis, and different things that it causes, like the first doctor spoke about PAD. One of the things that I kept having problems with my legs, and my doctors kept saying it was nothing, or they didn't think it was anything. However, I decided to go to a vascular doctor to see what's going on. And that's when I found out that that's what I had. And again, no other doctor told me this. I had to advocate for myself. I had to, make sure that I'm going out, getting checked. As it was stated before, we have insurance. You pay for insurance. If you pay for insurance, get the most that you can out of your insurance. That's what it's there for.
Well, yeah, it is. Your story is fascinating. So I know we're coming up on the end of our time here. So I want to give everybody, the doctors, that's why I brought y'all back, the opportunity to give your thoughts about Nicole's story.
It was very nice to meet you, Ms. Jefferson. And this is not fragmented, by the way. Everything and everyone on this panel, we're all interlinked. 30% of patients who have chronic kidney disease will have peripheral arterial disease. 50% who end up as a patient of Dr. Collins, as a dialysis patients, will have peripheral arterial disease. 1 in 2 adults who have diabetes do not know that they have diabetes. Majority of them are Black. And the fact that they are not screened on time or early on time, actually, most of them are Black women, to her point. The point is that we need policy also in place to change the way that our screening, these are all asymptomatic and silent diseases. Hypertension, silent killer, right? So why don't we have a task force that says there are people who are at a higher risk? We call them at-risk populations. People who look like us, who share certain characteristics, should be screened upstream. That is, the onus should not just be on patients to go and yes, advocacy is important, but our healthcare system needs to do better. And I think the onus is not only on us to advocate, but also on our healthcare system to have the U.S. Preventive Service Task Force change the screening, not only on PAD, but chronic kidney disease, which is currently lacking. That's something that I'm fighting on the Hill with congressional staffers as we speak. So we have to attack this at all fronts. And, patient stories are what matters, their lives and their livelihoods, to see them and hear their stories. So I just want to thank Mrs. Jefferson, thank the blackdoctor.org, and it's been an honor to share the platform. Dr. Martin Luther King said it best: of all forms of inequality, injustice in healthcare is the most shocking and inhumane because it leads to physical death. This is an example of it. So this is why we need to do better in diabetes. Thank you.
Boy, y'all are saying the word. I'm about to start shouting up in here. I'm about to go old school, y'all. Okay. As we're wrapping up here, Dr. Collins, any final thoughts?
So, Ms. Jefferson, thank you so much for your powerful story. And, for as many struggles as you've had, I would actually consider you to be one of our successes, right? We've certainly had people with greater challenges, with big time problems with access to medical care. One of the questions I was asked to consider before joining this panel was thinking of therapies that are, used for diabetic kidney disease specifically. So there's this new class of medications called SGLT2 inhibitors that many of you may have heard of. I'm sure you've seen commercials for them. It's so good, and the data behind them are so robust that now on the diabetes guidelines for the order of treatment is metformin number 1, and then this class of medications is not number 2. That said, insurance companies are not covering them. So I get in this fight, with the insurance company. So as Dr. Fakariti mentioned, that we really need policy changes to prioritize the therapies and the access to care that will actually improve health outcomes. And look, I'm a Black doctor who chose nephrology because I knew that kidney disease disproportionately affected Black people, not just from a life and death standpoint, but I think of it from an economic standpoint, because we're still trying to dig out of the hole of economic disenfranchisement that has been put on our people over the last 400 years in this country. How are we going to be able to get there if our people are not working? So I think of, treating diabetic eye disease, treating peripheral artery disease, treating diabetic kidney disease, and keeping people in the workforce, building and providing for their families to build on wealth in order to make the next generation of people who look like us have it better than we have it.
And
Hi,
Dr.
Phyllis, just a word. I really enjoyed your story as well. What I got from the story is that you advocated for yourself and you didn't take no for an answer. So that's really important. But if in fact there are people out there that are listening, if you don't feel that you're in a position to advocate for yourself, that's what Healing Our Village does. We can be your advocate. And so I'm going to put my 800 number in the chat. Please, we have professionals that are there to help you. But the other thing that I have to say before we leave is that COVID-19 is still around, that there are so many African Americans that have not been vaccinated. And there's new data that just came out that showed that COVID-19, the virus, actually caused diabetes and caused kidney disease in some susceptible people. So this idea of I'm just going to take my chances and get the virus, because it's just a virus. How bad can it be? It can be bad.
I've started enough people on dialysis because of COVID to attest to Dr. Coleman.
Thank you. So we need to get vaccinated. Again, Healing Our Village is doing this across the country. I love this idea of our health system doing a better job. I so much agree with that. But right now we're about to launch a church-based outreach. A lot of us are still in churches. And if you have a church that wants to get screened or wants to get educated, again, Healing Our Village is doing what we call Project Faith, which is fellowship and instruction toward health. So, we are here trying to make this thing happen on the ground. So thank you so much for the opportunity to talk to your audience.
This has been a wonderful, wonderful program. I wish it could continue, but we've got to get on. We're going to keep moving on with our Minority Health Summit here today on blackdoctor.org. We're going to be going on our next panel is going to be on clinical trials. So we're talking, Dr. Collins just talked about medications and things and whatnot. So we're going to be talking about clinical trials and what role they play in terms of improving our health outcomes. So I want to say thank you to all of our guests here. Dr. Fakariti, you are a rock star. We'd love to have you back. Dr. Collins, I'd love to have you. Let's do something more about our kidney health. And just to let y'all know, we do every other Friday. We have a show called Kidney Talks here on blackdoctor.org. It features Dr. Callender and Dr. Clive, Dr. Keith Melanson out of GW, and they do a wonderful job talking all about kidney health. So check that program out. Get your blood sugar checked. Be an advocate for yourself, as Nicole was, and also make your congresspeople know with your vote. So Dr. Fakariti is making a good point. He is going into legislation. Make sure your congresspeople know and let them know with your vote that, hey, our health is very important. So that's that. I will see y'all next time. Hey, go to the next panel. We're still going. Thank you. Y'all take care and have a great